presenters have been compensated for their time.
Welcome to Rapid Recaps, your place to explore the challenges of chronic spontaneous urticaria, or CSU, and learn more about RHAPSIDO or remibrutinib. In each episode, experts share knowledge to help healthcare professionals like you navigate CSU management with confidence. My name is Dr. Michael Blaze, and I'm joined by my colleagues specializing in CSU. Two leading experts from allergy and dermatology will share their insights on CSU, a condition that may present across specialties and in different clinical settings. Would you like to introduce yourselves?
Hello, I'm Dr. Priya Bansal.
And I'm Dr. Adam Friedman.
Welcome and thank you for joining us. Before we dive in, it's important to note that RHAPSIDO is indicated for the treatment of chronic spontaneous urticaria in adult patients who remain symptomatic despite H1 antihistamine treatment and is not indicated for other forms of urticaria. The important safety information and a link to the full prescribing information for RHAPSIDO are available nearby this video.
We'll review the data from the pivotal REMIX trials and show how RHAPSIDO helps to reduce symptoms of CSU. Our focus will be on secondary and exploratory endpoints, particularly the UAS-7, or the Urticaria Activity Score over 7 days, which captures disease activity in CSU. For a complete look at the study design and the primary endpoints, please explore our other detailed videos in this series. So Dr. Bansal, what were the primary endpoints used to evaluate efficacy in these studies?
The co-primary endpoints were hive severity and itch severity, and this is over 7 days at week 12, measured as the least square means change from baseline. The key secondary endpoints, which we're going to review, were the UAS-7 or Urticaria Activity Score, again over 7 days at week 12, proportion of patients with UAS-7 less than or equal to 6, or well-controlled disease at weeks 2 and 12, proportion of patients with UAS-7 equal to 0, or complete absence of disease activity at week 12. So yes, folks, you heard it here first. We're looking at the 0, right? Which is exciting for our urticaria patients. We're also going to look at the cumulative number of angioedema-free weeks measured by an angioedema activity score over 7 days, AAS-7 equal to 0 up to week 12. The efficacy of RHAPSIDO was assessed using what we call PROs, so patient-reported outcomes, and hives and itch are frequently assessed in clinical practice as key measures of disease activity in CSU. And I personally, this is what we use, right, in the clinic to figure out how a patient's doing. In the REMIX trials, the efficacy was also assessed with a UAS-7, which again, what is the UAS-7? This is your secondary endpoint, but we're looking at the combination of the two, the things that the patients are coming in talking to us about. The daily score for hives, or HSS-7, and the itch, which is ISS-7, that the patient summarized for each day over 7 days. The UAS-7 score range as follows. A UAS-7 score of 0 obviously is indicating, hey, I don't have hives and itch, and obviously the holy grail of what we're going for. 1 to 6 is well-controlled CSU, 7 to 15 is mild CSU, 16 to 27, now I'm layering, moderate CSU, and finally, way up here, a UAS score of 28 to 42 is indicating severe CSU. And the higher that score goes, the more severe the itching and hives, owing to that greater disease burden and underscoring the importance of utilizing these PROs of things we're seeing in patients to help uncover patients who have uncontrolled symptoms.
Continuing on, let's discuss the efficacy results. And as you can see in this table, both trials met their co-primary endpoints and showed similar reduction in hives and itch severity scores. Looking at these data, we can see that RHAPSIDO had a measurable change on patients in the trial.
As we review these charts, please note that there are limitations to understand. So no conclusions or comparisons can be drawn since post-hoc or pre-specified exploratory analyses were performed at week 1 and weeks 12 and 24 respectively. These analyses were not adjusted for multiplicity. After 24 weeks, all patients on placebo were crossed over to receive RHAPSIDO. Data after 24 should really be interpreted with caution due to the open label design and absence of a comparative control group. Week 52 data are a pre-specified exploratory analysis, and no statistical tests were done.
RHAPSIDO led to fast and significant improvements in disease activity at week 12, with an LS mean change from baseline of negative 19.41 with RHAPSIDO versus negative 11.73 with placebo. In week 1, a 38% reduction in UAS7 was observed with RHAPSIDO versus 7% with placebo. At week 12, it was a 69% reduction in UAS7 with RHAPSIDO versus 40% for placebo. And at week 24, that 73% reduction in UAS7 was observed with RHAPSIDO versus 48% with placebo. At week 52, again, during that open label period with that crossover, we're seeing that 75% reduction in UAS7 was observed with patients that were randomized to the RHAPSIDO arm at baseline.
So you've clearly seen how RHAPSIDO can reduce the severity of hives and itch. Now let's look at the data in well-controlled CSU. And honestly, for me, these slides are much easier to digest. This is kind of what I'm more used to in terms of the studies in dermatology. So hives and itch were well controlled as measured by UAS7 less than or equal to 6 as early as week 2. There's that need for speed in 30% of patients on RHAPSIDO versus 5.9% on placebo in REMIX 2. Now, week 12, 46.8% of patients on RHAPSIDO versus 19.6% on placebo had a UAS7 score of less than or equal to 6. In REMIX 2, nearly 5 times as many patients achieved well-controlled CSU with RHAPSIDO versus placebo at week 2. Now let's move to our next secondary endpoint, which is a UAS7 score of, drumroll, 0, that holy grail you heard about earlier, indicating a complete absence, devoid of hives and itch. At week 12, nearly 1 in 3 patients on RHAPSIDO achieved complete absence of hives and itch versus 6.5% with placebo. That represents approximately 4 times as many patients achieving complete absence of hives and itch compared to placebo. In REMIX 2, nearly 46% of patients randomized to the RHAPSIDO arm at baseline were completely free of hives and itch when assessed at 1 year. The limitations of the data are that no conclusion or comparisons can be drawn. Data after that week 24 should be interpreted with caution due to that open label design and absence of a control group. Week 52 data is a pre-specified exploratory analysis and no statistical tests were done.
The angioedema activity score, so that's the AAS7, and that's scored over 7 days. So it is a patient-reported outcome or a PRO that's addressing the severity of that physical discomfort, the ability to perform these daily activities, cosmetic impact, and global assessment of severity due to angioedema. An AAS7 score of 0, which is, woohoo, right? I got a drum roll every time for that. It's indicating a week without angioedema occurrence. At baseline, 46% of patients in REMIX 2 had prior angioedema. At week 12, patients on RHAPSIDO experienced more cumulative, non-consecutive angioedema-free weeks compared with placebo, with 8.81 weeks without angioedema occurrence with RHAPSIDO compared to 6.68 weeks with placebo based on that AAS7 of 0.
RHAPSIDO significantly reduced hives and itch, the 2 co-primary outcomes in the REMIX trials. We also reviewed the outcomes on angioedema, a key secondary endpoint. Dr. Friedman, now that we've reviewed the efficacy, can you take us through the safety data?
RHAPSIDO demonstrated a robust safety profile across 2 phase 3 trials up to 52 weeks. Out of the gate, that's a lot of information. Now, this table here shows adverse reactions that occurred at greater than or equal to 3% for the pooled phase 3 trials at week 24. That's where we still have that placebo arm. The most frequent adverse reactions were nasopharyngitis, bleeding, headache, nausea, and abdominal pain. In the pooled phase 3 trials, the safety profile of RHAPSIDO at 52 weeks was consistent with the safety profile at 24 weeks that you see here. Now let's take a little closer look at that bleeding, which I know you all want to hear about. The 9% of bleeding events were mucocutaneous related and no severe bleeding reactions occurred. Mucocutaneous bleeding events occurring in greater than or equal to 1% included petechiae, contusion, ecchymosis, and hematuria. Petechiae was reported in about 4% of patients treated with RHAPSIDO. Petechiae is considered a subset of skin and subcutaneous tissue disorders and is characterized by small, pinpoint, non-blanching red or purple spots caused by bleeding under the skin. Cases of petechiae were predominantly mild or moderate. Of the 23 patients who experienced petechiae while taking RHAPSIDO, only 1 discontinued treatment, and no patients in the placebo group discontinued treatment. Other mucocutaneous events reported in less than 1% of cases among patients treated with RHAPSIDO included purpura, epistaxis, and conjunctival bleeding, gingival bleeding, hematoma, hemorrhagic ovarian cyst, intramenstrual bleeding, and urinary occult blood positive. No association between bleeding reactions and low platelet counts was observed. Of note, anticoagulant medications and antiplatelet medication, except for acetylsalicylic acid up to 100 milligrams a day, or clopidogrel up to 75 milligrams per day, were not allowed in the study. The use of dual antiplatelet therapy, like acetylsalicylic acid and clopidogrel, was prohibited.
I hope this information about additional key data provides a deeper understanding of how RHAPSIDO may help your patients.
Indication: RHAPSIDO, remibrutinib, is indicated for the treatment of chronic spontaneous urticaria, CSU, in adult patients who remain symptomatic despite H1 antihistamine treatment. Limitations of use: RHAPSIDO is not indicated for other forms of urticaria. Important safety information. Warnings and precautions. Risk of bleeding. Mucocutaneous-related bleeding occurred in 9% of patients who received RHAPSIDO. Interrupt treatment with RHAPSIDO if bleeding is observed, and resume if the benefit is expected to outweigh the risk. Interrupt treatment with RHAPSIDO for 3 to 7 days pre- and post-surgery or invasive procedures. Use of antithrombotic agents concomitantly with RHAPSIDO may further increase the risk of bleeding. Consider the benefits and risks of antithrombotic agents when used with RHAPSIDO. Monitor for signs and symptoms of bleeding. The use of live and live-attenuated vaccines should be avoided in patients receiving RHAPSIDO. Adverse reactions. The most common adverse reactions, incidence greater than or equal to 3%, were nasopharyngitis, bleeding, headache, nausea, and abdominal pain. Drug interactions. Remibrutinib is a CYP3A4 substrate and a P-glycoprotein (PGP) inhibitor. Avoid use of RHAPSIDO with strong or moderate CYP3A4 inhibitors. Concomitant use with a strong or moderate CYP3A4 inhibitor increases remibrutinib exposure, which may increase the risk of RHAPSIDO adverse reactions. Avoid use of RHAPSIDO with strong or moderate CYP3A4 inducers. Concomitant use with a strong or moderate CYP3A4 inducer decreases remibrutinib exposure, which may decrease the efficacy of RHAPSIDO. Monitor more frequently for adverse reactions when using RHAPSIDO with PGP substrates where minimal concentration changes may lead to serious adverse reactions, for example, digoxin. Remibrutinib increases exposure of PGP substrates, which may increase the risk of adverse reactions related to PGP substrates. No data are available on concomitant use of RHAPSIDO with anticoagulants. The concomitant use of RHAPSIDO and anticoagulants was not allowed in clinical studies. Use of the antiplatelet agents acetylsalicylic acid at doses up to 100 milligrams daily or clopidogrel up to 75 milligrams daily was allowed in the RHAPSIDO clinical studies. Use in specific populations. There is a pregnancy exposure registry that monitors pregnancy outcomes in women exposed to RHAPSIDO during pregnancy. Avoid use of RHAPSIDO in patients with mild, moderate, or severe hepatic impairment, Child-Pugh Class A, B, and C. RHAPSIDO exposure is increased in these patients relative to patients with normal hepatic function.
This wraps up this video. Thank you for watching Rapid Recaps on RHAPSIDO. We invite you to explore the other videos in the series to learn more about RHAPSIDO and its role in CSU treatment. Explore clinical insights and treatment considerations for CSU at rhapsido-hcp.com.